So we'll be discussing about NK T cell lymphoma today. He presented to us with history of nasal block of 4 months duration and a neck swelling of 4 months duration. The patient was apparently normal 4 months back. Then she developed a nasal block on the left side initially, which later gradually progressed, and the right side nostril was also involved. Patient has difficulty in breathing. She complains of occasional blood tinged discharge, which was seen mostly when she was blowing her nose, and it was relieved when she took steam inhalation. There was history of nasal twang of voice. There was occasional headache and on and off fever which was present. Patient did not have any other symptoms like altered vision, dual vision, altered sensations of the face, loosening of teeth, difficulty in mouth opening, dysphagia, dyspnea, chest pain, or any other associated complaints. Patient did not consume tobacco in any form or tobacco or alcohol in any form. There's no history of sharp teeth or consumption of spicy foods. Past history, the patient did not have any similar complaints in the past. There is no previous history of surgery also. Coming to family history, there's no history of similar illness in the family. So coming to the general examination, the patient is conscious, cooperative, moderately built and nourished, oriented to time, place, and person, and her vitals are also stable. General examination, there was no pallor, icterus, cyanosis, clubbing, or pedal edema. Generalized lymphadenopathy was present, which I'll be elaborating in the examination part. Coming to local examination of head and neck, mouth opening was adequate. Her oral hygiene was fair. There was no loss of teeth. Oral cavity, as such, we didn't find any lesions. There was a granulomatous small lesion in the hard palate, which is like white in color of size 1 by 1 centimeter, ovoid in shape and has an irregular surface. The tongue movements are, however, normal. Nasal cavity, bilaterally it is symmetrical. There is no deviated nasal septum, but patient has a bilateral nasal block. She is unable to breathe through both the nostrils. Increased mouth breathing was present. No lesions were detected on inspection or palpation of the nasal cavity. Coming to examination of the neck, on inspection, there was only a fullness we could appreciate in the left neck. On palpation, there was multiple bilateral lymph nodes which were palpable in the neck of varying sizes. Largest of which was around 1.5 by 1 centimeter, present on both sides in the level 2, 3, 4 of neck. All the nodes were round to oval in shape. They had smooth surface, which was soft to firm in consistency. The skin was normal and thyroid gland was also normal. Systemic examination was unremarkable. So this patient came to us with a outside USG report of the USG neck showing bilateral cervical nodal enlargement, which was it was reported as query secondary to infective etiology, and there was a thyroids 1 nodule in the left lobe of thyroid. So further, they had done a MRI neck from outside itself. So there was a large conglomerated nodal mass reported by 5.4 by 4.2 centimeter in the left neck in level 2 and 3. The nodes compressed the IJV, and another 2.3 by 1.4 centimeter left prevertebral node was also seen at the level of C1 and C2. Multiple other smaller nodes were also reported in level 4 and level 5. There was soft tissue thickening with contrast enhancement in the left lateral nasopharynx, and adjacent left lateral pharyngeal wall thickening was seen. So when she came to us, we did a PET CT for staging workup. So that was a like high-grade hypermetabolic ill-defined lesion involving the nasopharynx, which was extending to involve the bilateral lateral oral pharyngeal walls, tonsillar foci, and soft palate, and hypermetabolic bilateral cervical and supraclavicular nodes were reported, possibly lymphomatous involvement. High-grade hypermetabolic mild soft tissue thickening involving the bilateral nasal cavity was also described, associated with splenomegaly. The patient had undergone FNAC from outside, which was outside reported as atypical lymphoid hyperplasia. The baseline CRP done at MVR was 7.7 and ESR was 41. The patient had undergone a nasopharyngoscopy and undergone a biopsy, which was reported as query NHL only. Outside IHC reports were not available when she first came. So from MVR, we actually reviewed her slide and block. For the pathology part, I would like to hand over to Anman.
Okay, so we had received this specimen of a 26-year-old female who had complained of some nasal symptoms like epistaxis, nasal twang of voice. There was a lesion in the nasopharynx. By the time we got the slides, we had the PET report, which showed us a cervical lymph node as well as splenomegaly with uptake in spleen. So with this history, we are kind of biased towards some significant pathology because splenomegaly, lymphadenopathy, and a nasal lesion. So we'll see what is under the microscopy. So this is what we had received. It was a fragmented biopsy. So if you see here, there are multiple fragments of tissue. Yeah. Okay. So we can appreciate the multiple fragments of tissue. We'll focus on one of the fragment. So if you see here in this fragment, there is a lining mucosa. So it is lined by a mucosa. Now we'll see what kind of mucosa is this. Okay, so if you see here, so this is stratified epithelium. Yeah, and at few places we would be able to appreciate the cilia. We'll show you the cilia. It's not moving out. Sorry. So the mucosa is a respiratory mucosa. Once again, I'll show you. So I'm confident that okay, this is a biopsy taken from the nasopharynx by seeing the respiratory mucosa. So I think we can appreciate the cilia here. Yeah, stratified columnar epithelium cilia. Okay, now we'll go on to the submucosal tissue. So if you look at this tissue bit, so this looks like a lymph node. No, the submucosa looks, it's densely blue in color. A lot of the small blue dots, and you are seeing some sort of follicles out here. It looks like a lymphoid tissue, right? It looks like I'm looking at a lymph node. So normally under the submucosa, we are supposed to see submucosal glands and the normal architecture, but which I'm not able to appreciate here. So nasopharynx is one place where we can get a florid lymphoid proliferation, lymphoid in proliferation normally also. But then we usually don't see destruction of normal architecture. So whenever the normal architecture is destroyed, our red flags go up. Is it something pathological? Because normal reactive lymph nodes are very innocuous. No, they actually maintain the boundaries, they respect the boundaries, they trickle through the in between the normal architecture, they never destroy the normal architecture. So seeing this destruction of a normal architecture, which is making me very apprehensive. So wherever I look, I'm not able to appreciate anything other than the dense lymphoid infiltrate out here. Okay, which is very worrisome. Now, what I'm going to see here, if you see here, there are some, so these areas are looking very, very blue. You can see small, tiny blue dots. But coming on to this area, there's hardly any blue. It's very pink, perfectly pink. So why is it so pink here? So if you look at here, it's pink because there is no nucleus. So you can see small blue dots. These are the apoptotic bodies. So they are the dying. All these cells are dying out. Yeah, and if you see here, you can hardly make any cell outlines, all very pink. So this is a necrosis. Okay, and this necrosis is, it is called as a coagulative necrosis because we are not seeing any tumor cell outline. It is looking very mushy. So there is areas of coagulative necrosis out here. So whenever we pathologists hear or see coagulative necrosis, our reflex is to think about any microorganism. So coagulative necrosis, microorganism do special stains. Yeah. So, and then we look for, do we see any outline of any aspergillus or fungus or mucormycosis out inside here? But then there is nothing of that sort here. But then the necrosis is kind of coagulative. So why is this necrosis happening here? So is it the patient is having a history of fever? There is necrosis which is looking coagulative. Is it because of some fungal infection? Do I need to do some special stains? Now we'll go into this fragment. Now, when I look at this fragment, again, I was talking about these blue dots. These are the lymphoid cells. Okay, around the blue dots, I'm seeing some white areas. So normally lymphoid cells lack cytoplasm. So whenever I see a lymphoid cells with a pale area, The differential is either T cells or marginal zone lymphoma. These are the lymphomas, or a normal T cell which can appear, which can have a lot of cytoplasm. So these lymphoid cells have a lot of pale areas around. So some sort of, in the reactive condition also you will have florid T cell proliferation. So could it be the normal reactive T lymphoid proliferation in response to some fungal infection, some coagulative necrosis happening here? Okay, so we'll see. But then they are having very hyperchromatic nuclei. And if you see here, once again, you can see these vessels. So there's some sort of vascular proliferation happening in addition to the lymphoid proliferation. Okay. And if you see carefully, these tumor cells are actually infiltrating into these vessels. This was a vessel out here, which has been completely destroyed. There is angio invasion and angio destruction. Okay, these lymphoid, so-called atypical lymphoid cells. I have not yet decided what it is, whether it is a lymphoma, whether it is some reactive lymphoid proliferation. But then they are seen to destroy. They are going to they are seen. So there was a vessel here which was completely destroyed. These vessels are being infiltrated by these lymphoid cells. This doesn't look very good. Okay, and as we go through here, these cells, you see here. So this was a cell here. As we go here, it's completely pink. So now we have understood why this necrosis is happening. There are some cells which is going and destroying and plugging the vessel, causing ischemia, just causing this necrosis out here to happen. Okay, so now we have explained the necrosis, the coagulative necrosis. So usually in lymphomas, we don't see necrosis. Even in Burkitt lymphoma, which has 100% proliferative index, the highly proliferative, we hardly find necrosis. Very, very rarely in lymphoma, we get necrosis. And some of the cases are Hodgkin lymphoma, EBV-related DLBCL, and this NK T cell lymphomas. Okay, or in another situation is that when the clinician had given a dose of steroid and then taken a biopsy, all the lymphoid cells have undergone necrosis. So necrosis is not a common phenomenon in a lymphoma. And the etiology of necrosis here is not because of the dying cells, but because of the angio destruction and angio invasion, which has caused ischemia and led to the necrosis. Okay. So now we'll focus a little bit on those individual cells. Are those cells atypical truly? So how do you say a cell is atypical? You will always hear in our report the nuclear membrane irregularity, the hypochromatic nuclei, the nucleoli. Okay, so we'll try to see one of the fragments out here and see how the cell looks like. 1 second. Yeah. So if you look at these cells, some of them are very nice rounded. Okay, fine. But then this cell is very pale, but here if you say the cells, the nuclear chromatin has become darker, hyperchromatic. There is a sort of cleaving out here, the nuclear membrane irregularity, very, very fine, with an eye, which an eye of a pathologist can only detect. Maybe my medical oncology colleagues, it may find it difficult to believe that, oh, some of them are atypical, but believe me, these are atypical cells. So their nuclear membrane are irregular. And I'm not very happy. These are not how a normal lymphoid cells are supposed to look at, especially the cells out here. A lot of cytoplasm, they're showing angio destruction, angio invasion. So morphology wise, I'm super biased towards some sort of atypical lymphoid proliferation happening out here. Yes, irregular nuclear contour. Okay, so some of them are prominent nucleoli. So super biased towards an atypical lymphoid proliferation. Now I'm waiting for my IHC to see what is it. So my first panel in any case of, so my IHC is now thinking about a lymphoma panel. I'm not thinking about a carcinoma here because these cells are not cohesive. These are very diffusely arranged, singly trickling cells. I'm not thinking about carcinoma here. What we see here, these are the normal glands out here, some of the normal mucosal glands, but okay. So I'm not thinking about a carcinoma. I'm not thinking about a sarcoma. Because of this morphology, my differential is an atypical lymphoid proliferation, and my first panel would be a 3, 20, and Ki67. 3 and 20 to see what lineage should I go. Should I go through the B lineage or should I think about a T lineage? Okay, so now I'll show you the 3 and 20. So in 3 and 20, this is okay. And what sort of lymphoma am I thinking about here? It's a non-Hodgkin lymphoma because it is a diffusely proliferating looking cells. Unlike Hodgkin lymphoma, where we see a single large Hodgkin-like cells. So my panel is a lymphoma panel of a non-Hodgkin lymphoma panel. A non-Hodgkin lymphoma panel, first is 320 and MIB1. And what I'm expecting in a non-Hodgkin lymphoma, if it is at 20, I will see the entire lymphoid cells taking up 20 diffusely. This is my normal control where a normal lymph node is. My 20 has worked. Now I'll go into my tissue section. So this is a tissue showing 20. These are the different fragments. So if you see, many of the fragments are completely, sorry, is it visible?
No.
Is it visible now? Yeah.
Yes.
There is a fragment out here. Yeah, many of the fragments are negative for CD20. Yeah. And one of this fragment is. Yes, ma'am.
Focus it, and then stop. Okay.
Yes, ma'am. So one of this fragment is showing some amount of CD20, but rest of the fragments are negative for CD20. I'll come into high power. I will come into high power. So this is one of the fragments which is showing CD20 now. Is it a B-cell lymphoma? There are taking up some of the CD20. But if you see, these 20 are taking up in a normal lymphoid follicle. And this was not one of the fragments where I was convinced of atypical lymphoid cells. So we need to interpret our IHC with our morphology. Yeah, this fragment, if you see, this could be a normal B lymphoid follicles. And the fragments which I was worried about was those with those necrosis, with those atypical lymphoid cells, these fragments, which are actually completely negative for CD20. Okay. So this was a CD20. I'm not thinking about a B-cell lymphoma with this CD20. Just highlighted a few cells here, but these are my cells which I am worried about, which are not taken up CD20. Now we'll go to CD3. CD3. Okay, if it was a T-cell lymphoma, I'm expecting diffuse strong CD3 positivity. Okay, in a normal scenario, in a usual T-cell lymphoma. So what am I seeing here? This is also highlighting a few cells here and there. Not very happy with the CD23. With the CD3, I can't call it as a T-cell lymphoma. No. I need to see diffuse brown color. Okay, there are some cells which are taking up CD3. Now we will go and see in our area of interest, these cells. You see some of the cells have taken up CD3, but many of them are actually negative for CD3. See those cells? These cells are actually negative for CD3. And then the small cells in the background have taken up CD3. So I'm not very sure these background cells could be reactive T cells. The CD3 is not good enough for me to call it as a T cell lymphoma. And this could be a mixture of reactive B and T cells. So just by my CD3 and 20, maybe if I had not seen the morphology and just seen this IHC, I would have neglected and called it as a reactive. Coming into Ki67. So Ki67 is not very high in this fragment. This was the fragment where we had seen the B. These were taken up CD20. This was the reactive. So this area was a reactive lymphoid proliferative area, not very high MIB. But then there were these areas. Our area of interest. So you remember this was the fragment which had shown necrosis here and some of the cells here, tumor cells here. The MIB is kind of high. Majority of the cells have taken up MIB. If I'm going to come 100 cells, maybe 40%. There are some areas where it's showing higher MIB. We'll show some of the areas. Okay. So these cells are taken up quite high MIB. Yeah, this MIB is quite high. So I have not yet reached my diagnosis. 320 has not helped me much. MIB is kind of high, but morphology looks very bad. So I did put my, that was my first panel. I did put my second panel of 7, 5 and 56. Because nasopharynx with this morphology of angiodestruction, angioinvasion, and typical lymphoid cells, I had already had a differential in my mind of NK T cell. So an NK T cell is notorious for showing loss of CD3. So normally a lymphoma, CD3 is a very robust marker for T cell lymphoma. A CD3 will be positive. Unlike in B cell lymphoma, we can have some of the B cell lymphoma losing CD20, but then CD3 is a very robust marker. And usually in lymphomas, T cell lymphoma, 7 is the marker which is lost. Okay, but NK T cell is one such lymphoma which show loss of surface CD3 and retained CD2 and variable positivity for 7. So sometimes CD7 can also be negative in NK T cell. So luckily for us, CD7 was positive. And if you see the CD7, kind of almost every cell have taken up the CD7 in our area of interest. You see, I'll show you. Here, entire thing is lightened up. This is what I want to see in a lymphoma. I want a non-Hodgkin lymphoma. I want to see very diffuse brown color. Entire cell should be T cells or entire cell should be B cells with a CD20 B cell lymphoma. So I'm happy now. Okay, the entire cells are CD7 positive. But does this CD7 positive alone make it abnormal? So to call anything a T cell lymphoma, the abnormality what we see, we don't have a clonality marker as such in IHC. So we say that T cell lymphoma is abnormal based on morphology and immunohistochemistry. Some of the features which favor is that a loss of T cell marker. So T cell markers are 3, 7, 2, and 5. We have 4 T cell markers. And normally a reactive lymphoid cell, a T cell should retain all these markers should be retained. When there is a loss of the T cell marker, that is worrisome. And then that is the first feature which will tell that, okay, these T cells are not good. The second thing is the 4:8 ratio. So normally a 4:8 ratio is around 2:1 to 8:1. Yeah. So if the T cells are completely 4 positive or completely 8 positive or double negative for 4 and 8, double positive for 4 and 8, the ratio is altered. That is also worrisome. So as such, we don't have a clonality IHC for lymphoma. For checking for clonality, either we have to do a flow for TCR-V beta. We have a new marker which have come. We have in our institute TRBC1, or we have to send for molecular. So in morphology, we say this is a lymphoma. This is abnormal by the histomorphology as well as the loss of T cell marker and when the 4:8 ratio is skewed. Now I have shown you that there is a loss of T. The T was not as brown as the 7. So entire cells have taken up 7. So there is a loss of 3 here. But is that enough for me to call it as a lymphoma? No. I would like to see more. So now this was our 7. All of you are convinced, I hope, that the 7 is very positive. And I will show you the 3 once again. So compared to the 7, if you see this fragment, this was my 3. Well, it's very, very little, taken up little. No, so there is definitely a loss of 3 here. This is my 3. And this was my 7. Okay, so loss of T. Now 5, CD5. CD5 also is kind of taken up like CD3, very little. There is loss of CD5 also. So if I had not, if the CD7 was also lost, I would have been at a bit of a soup because there is no I would have no T cell markers have taken up. How can I call it as a T cell lymphoma? So luckily for us, the 7 is retained. So this is the CD5, which is also showing loss. Okay. Now coming on to the marker, since I was thinking about NK T cell lymphoma, I did put CD56, which is one of the very, very important markers. So to diagnose NK T cell marker, if you say what are the markers to be used, they are CD56, Eberish, and loss of CD3, and cytotoxic markers like granzyme, perforin. Okay, so I've put CD56 here. So if you see, the cells have taken up CD56, and this amount of CD56 is enough for me because normally we are not supposed to see so much of CD56 positivity in a lymphocyte. CD56 is an NK cell marker. 56, 57, 16 are all NK cell markers. Now they have taken up this 56, they have taken up 7. Okay, so it is a immunophenotype of an NK cell. Loss of 3, retain 7, and 56 is a phenotype of NK. So this is an NK cell marker. So I'm more happy. Yeah. But then, yeah, you can still call this, this much is sufficient to call with this morphology NK T cell lymphoma. But if you want to be 100% sure, if somebody asks me, are you 100% sure it is NK T cell lymphoma? What would you like to do? Then I will say EBV. So EBV is positive in majority, almost 99% of the cases. There are NK T cell lymphoma very, very rare, which are either negative, EBV negative, but 99.9% of cases, it is EBV positive. So since the tissue was very, very scanned, and each time I was doing IHC, I was scared whether the tissue will get depleted. So instead of doing a 4-8 next, I sent it to, we didn't have EBV, we don't have in-house EBV, but hopefully by the end of this month, we'll be able to start EBER. We have got the quotation. So since the tissue was very scanned, we sent the slide to BMH for doing EBER. So EBER is a nuclear stain for EBV. Okay, so I will show you the positive control. So before interpreting EBER, we'll have to look at the positive and negative control. So negative control, why? This is the negative control where it is completely pink, because I don't want to see, no, it should not be any non-specific blue dots here and there, which I'm falsely interpreting it as positive. So then my negative control is entirely pink. I'm happy. There's not going to be any false positive staining here and there. I'm going to look at my positive control of EBER. This is my positive control. This probably is a case of a Hodgkin lymphoma where the Hodgkin cells have taken up EBER. So the positive control has worked. So my IHC has worked. It is not going to show any non-specific staining. Now I'm going to interpret on my normal test slide. So this is my test slide. And if you see here, EBER has come out positive. So try avoiding interpreting in a necrosis. Areas of necrosis can show false positivity. So I will try to see when my viable areas where I'm whether they are truly positive or not. One second, let me just focus one of the sections. It was a section. So see the nuclear blue stain. The blue nuclear dot stain. So these are taken up the positive nuclear stain of EBER. So just few words on EBER. EBER is a very robust marker for detection of EBV. So in pathology, we can detect EBV either by an IHC, which is EBV LMP, or a nuclear stain. This is the in situ hybridization. We are detecting the DNA. So the antibody goes and bites with the DNA. In IHC, we detect the protein. Okay, so either by detecting the LMP protein of an EBV by IHC, or detecting the DNA, which goes putting an antibody which goes and directly bind to the DNA, that's the ISH staining, we can detect EBV. So EBV normally shows different types of latency in our body. That is, in different types of lymphoma, they show different types of latency. They occur in our human body as an episome, as a latent gene in episome, and in different stages, in latency 1, 2, and 3. In different stages, they will express different genes. Okay, but no matter what stage of latency it is, EBER-ish is always expressed. So EBER-ish is the golden marker which is to be used if you really want to detect EBV. But LMP IHC will be absent in latency type 1. Okay, and NK T cell lymphoma shows type 1 and type 2 latency. So if we try to put an EBV LMP IHC instead of EBER, we may get a negative IHC here. So we need to know what marker are we putting, where are we expecting it to be positive, or is it positive? A lot of things are involved here. So EBER-ish is a very, very robust marker for EBV, and hopefully by the end of this month, we will be able to start EBER in our institute. So to summarize the whole thing, this was a female who had shown a nasal friable mass, okay, and the morphology had shown atypical cells which were showing angio invasion and angio destruction, okay, and there was necrosis, and these atypical cells were of NK T cell immunophenotype. Why NK T cell? because they had shown positivity for 7, positivity for 56. They had shown loss of CD3, and then Eber-ish, the golden marker was positive. So there is no doubt in the diagnosis here. It is a case of NK T cell lymphoma. Thank you.